make sure this turns on.
I'm excited to hear this talk.
Can everybody hear?
Yes.
Do I need this? Maybe? Yes? Yes? Okay. So small, intimate audience, which is awesome because it's actionable. I'm Dr. Scott Martin. By way of introduction, I'm an interventional pain doctor, have been for 25 years. I am the Chief Medical Officer for the Institute of Regenerative Education. The Institute of Regenerative Education is a peer-to-peer education and online forum for training any and all providers with respect to regenerative medicine. That is a sister company for a biologics company called Platinum Biologics. Over the past 5-6 years, I've trained probably 5,000 providers on how to use biologics in their practice. I dedicate 50, almost 60 hours a week to individual training. This is nurse practitioner level, provider level, clinic owner level. I've taken 14 papers to publication in the past 5 years in the regenerative medicine space. I'm one of 2 doctors in the country that represents providers at the federal level of appeals, the attorney general level of appeals, as well as medical board level of appeals. And I have won cases at all of them. We're going to keep this actionable, and we're going to keep this very practical. Now, by show of hands, what are most people in the audience? Are doctors, nurse practitioners? Nurse practitioners, PAs. Okay. Are you in private practice? Yes, all of you? Outstanding. The world is changing. And it's not changing a little bit, it's actually changing quite a lot. Most of you would think it completely insane that 40 states in the United States have marijuana laws 10 years ago. No one would have thought that marijuana was even going to be legal. Yet every state in the country has a CBD law, and 40 states in the country have marijuana laws. By show of hands, does anybody know how many states have stem cell laws on the books? Meaning laws that state, I know you know, laws that state that if you want to use unapproved products that the FDA has not registered as drugs, you can do so in the course of your practice. There are actually 2 states right now. State of Florida, the entire state of Florida, right? As well as the state of Utah. Now, there are multiple other states that are looking at passing stem cell bills this year. State of Alabama is looking at passing a stem cell bill. State of Nevada is looking at passing a stem cell bill. Those stem cell bills are going to change the face of medicine as you all know it and as I know it, right? And there's a reason for that. In the regenerative medicine marketplace, does anybody know the value for OA of the knee? Just osteoarthritis of the knee. Does anyone have any clue how much that simple joint is worth to big pharma every year? Conservatively, $5 to $6 billion. That's just OA of the knee. Just OA of the knee, all right? Now that excludes big hospital as well as big device. We're just talking big pharma. This is a $5 to $6 billion industry, right? Big hospital, another $5 to $6 billion. Big device, probably another $2 billion, right? Knee OA is a $15 billion industry. What's the primary drug used to treat osteoarthritis? Meloxicam. It's actually an NSAID. I wish it was Tylenol, it's not, right? It's actually a nonsteroidal. Now, care to guess how many patients die every year from narcotic overdose? Too many, yes, but we're specific, right? Around 100,000 people die a year from narcotic overdose, right? Now this has nothing to do with fentanyl overdoses in the street, marijuana laced with fentanyl, any of that stuff. This is just straight narcotic overdose from prescription narcotics, all right? The most we ever lost was in about 2016, and we lost a little over 140,000 lives to narcotic overdose, right at the height of the narcotic epidemic. How many patients die every year from NSAIDs? Rough guess. The conservative estimate is 250,000. So we lose almost threefold more patients every year from NSAIDs than we do to narcotics. And I see question looks on people's faces, right? Why? Why should that shock people? Because you've never heard it other than from me. Most of you don't know that that 250,000 estimate is egregiously low. It's more like 1 million patients a year die from NSAID-related complications. 1 million. Why am I talking about NSAIDs and we're talking about regenerative medicine? Well, I opened with the fact that just for big pharma, OA of the knee is a $5 to $6 billion industry every year. How do we get osteoarthritis of the knee? We're going to go through a very simple paradigm, all right? We get osteoarthritis of the knee based on natural history of degeneration for that joint. Very early on, based on gravity, because we're stuck here, based on trauma, simple aberrant forces through the knee, injuries, all right, you get something called fibrillation of articular cartilage, the structural cartilage that makes up the end plates of every joint in your body. That's every end plate in your wrist, your fingers, knee, shoulder, hip, all right? That initial trauma breaks down the crosslinks in that cartilage. With further trauma, further degeneration, just more time, we have an initial anabolic phase of the chondrocyte, the very cells that create new collagen, all right? That is very short-lived. And shortly thereafter, we have an inflammatory response where inflammation actually breaks down the cartilage in our joints. Are NSAIDs anabolic or catabolic to the critical cartilage that makes up the end plates of every single one of our joints? Catabolic. And they're the #1 prescribed thing for OA. Think about that. The #1 prescribed drug in the United States is catabolic, and it breaks down the critical cartilage that allows us to simply negotiate our environment. Seems a little counterproductive, right? But it's extremely profitable, all right? Now, how many different types of collagen are there in a knee? It's actually 3, right? Every one of you sitting here has 3 different types of collagen in your knee, right? The articular cartilage that's over the femoral condyles and the tibial plateau is type 2. All of the structures that support the knee, the synovium, the ACL, the PCL, the MCL, the LCL, the medial meniscus, lateral meniscus, are type 1 and type 3 collagen. Now, I know that you're thinking to yourself, what on earth does this have to do with regenerative medicine? I'm going to get down to it. The articular cartilage that's in all of our joints, our bodies stop making at the age of 20 to 25. Now, just looking at everyone in the audience, except maybe her, everyone here is older than 25. So none of you actually make type 2 collagen. None of you. If any of you are leaving and you slip on your way out that door, fall to the ground, and you tear the meniscus of your knee, you will have torn type 1 and type 3 collagen, and your body stops making type 3 collagen at the age of 35. So if you tear your meniscus and you're older than 35 years of age, your body doesn't make type 2 collagen or type 3 collagen. The only collagen that's in any of the stem cells in our body, the stem cells found in our blood, our bone, our fat, are type 1 collagen, and that's it. That's it. We fall, we injure ourselves, we scar. Type 1 collagen is a scar. It is nowhere near as strong as native tissue, and it breaks down faster than native tissue. This is why any of you who've had any injury, whether it was sports related or traumatic, you get injured again. Anyone who's ever told me they had a medial meniscus surgery, it's not one. They've had 1 or 2 or 4 surgeries, right? And they end up getting a knee replacement at a young age. Why? Because the body doesn't repair itself the same way. By show of hands, can anyone describe for me in detail a fall they had at the age of 3? You all laugh, right? Why do you laugh? Is it that you don't remember? No, when we're 3, if we fall, our body has an amazing capacity to heal itself. We just bounce back up and we go on our merry way. Now, we could have fallen really hard, right? Look, if I fall off this stage, I'm going to roll over and take a nap, right? Because I ain't bouncing back up. And I work out sometimes twice a day. But at 53, my body lacks the ability to repair itself at a cellular level. Full stop. That's it. I'm going to teach you stem cell medicine in 10 minutes. And I do this all over the country and all over the world. All right? Most of you are eating or snacking or postprandial, so you're half falling asleep, right? This is why I have no slides, because I think slides are nonsense, right? If I don't know the material well enough to tell it to you, I don't need a slide, right? We're going to make this very simple. Everyone knows what a triangle is, correct? All right? I want you to visualize a triangle. This triangle is how we describe all biologics, all right? Now, have any of you heard that people go to like Mexico or Cancun or Costa Rica for stem cells? Yes? Okay. It's critically important to understand stem cell medicine we practice here in the States, stem cell medicine they practice there, all right? Now, first of all, many of you have seen Joe Rogan talk about getting stem cells overseas. Maybe you've seen podcasters get stem cells overseas. I would like to say I have nothing wrong with Mexico or Costa Rica, but if you wouldn't drink the water, do you really want to take something like that and put it in an IV and give yourself a large dose of that and spend $20,000? Because any of the instruments or equipment that they're sterilizing, they're using water, right? Now, I mean, I don't know if they mix stuff up with their big toe. I have no idea, right? But still, I wouldn't risk that overseas. That's number one. Now, number two, when we talk about stem cells overseas, this is critically important. We're going to do a little history here. The stem cell medicine they use overseas, they use pluripotent stem cells, typically from aborted fetuses. All right? There are a lot of ethical considerations that have to be weighed there, right? They don't have the same FDA that we do, but there's a bit more nuance to this. Pluripotent stem cells have the ability to turn into anything in the human body, anything, including cancer. Does everyone remember that we cloned a sheep? Very good, Dolly, right? We cloned a sheep named Dolly, right? Wonderful, right? This was going to be the best thing in the world, right? We were going to clone eyeballs and ears and kidneys and new meniscus and, another arm if I just I didn't like the way that looked, it was just going to grow an arm, right? Does anybody remember what happened to Dolly? Who said that? Did she die from cancer? She did. Dolly died of metastatic cancer at the age of 5. That is not what halted the human cloning project. This was going to be a very big thing, right on the tails of the Human Genome Project, the Human Cloning Project. What most people don't know is that Dolly had 5 baby sheep, and all 5 baby sheep died of metastatic cancer within a year of life. That is what put the nail in the coffin for the Human Cloning Project. And that is why pluripotent stem cells have been illegal in the United States since George W. Bush was president. Like him or not, he made that illegal. So what do we have here in the United States now? We have something called differentiated mesenchymal stem cells, all right? Karen did a wonderful job lecturing this morning. She talked about 3 of the potential sources from your own body, right? You can harvest stem cells from blood, from bone, and from fat. All right? But can you really? Can you really? How many differentiated mesenchymal stem cells are in your blood? If I pull your blood and I spin them down, and most of you may have heard of PRP, some of you might even do PRP, some of you have seen ads for PRP being a regenerative therapy, restoring function, regenerating cartilage. I'm here to tell you that's bullshit. Because there are this many differentiated mesenchymal stem cells in PRP. None. Absolutely zero. What if I stick a 14-gauge trocar? A 14-gauge trocar is the size of my finger. And I'm going to drill this into your hip. Now, if you just happen to be female and 65 and you have osteopenia, what happens when I drill something the size of my finger into your hip? Sacral incompetence fracture, right? What if I decide to take it from your tibia? Because podiatrists can't work above the knee, and many of them like to do bone marrow. So if you can't work above the knee, where do you pull the bone marrow from? I stick my finger through your tibia. Zzz. Is it possible to shatter the tibia mid-shaft? Yes, it is, right? Has this happened? Yes, it has, right? The differentiated mesenchymal stem cell yield, as published in literature from 2016, is 0.001% of the yield. That's about as much Native American as Elizabeth Warren. Sorry, political joke. My point, it's not a lot, right? 0.001% is not a lot. The best source of differentiated mesenchymal stem cells in the human body is not belly fat. Many would let you believe that. It's not belly fat. It would be lovely if it was, because everyone could get, really thin and we get a bunch of stem cells. The best source of differentiated mesenchymal stem cells in the human body is called Hoffa's fat pad, or the infrapatellar fat pad, which sits behind the knee joint, all right? Meaning the only way to access that is from arthroscopy. Now, are there any orthopedic surgeons in the audience? All right, since there are none, none of you can harvest Hoffa's fat pad because you have to go through the knee joint to do it. So imagine doing a liposuction with repeated suction ramming through the knee joint itself, right? You might get some stem cells, but you also get a hemarthrosis, right? And you probably destroy meniscus and God knows whatever else. The biologics that I've used since 2015 are umbilical cord tissue derived. How many of you have had children? Women, of course. All right. All of you at the time you delivered would have signed a consent form. And that consent form essentially stated that you volunteered to donate your umbilical cord and your placenta for the purposes of research. That was the initial intent, right? And I stick to that initial intent. I'm very, very big on research. There are 250 companies in the US that sell, quote, stem cells. Damn few do research, right? The umbilical cord is on average, it's a little bigger than this, right? The umbilical cord is on average 28 centimeters long, all right? If I open the skin of the umbilical cord, the epithelial layer, and I strip out the 3 blood vessels, the primordial tissue inside is the most robust growth factor complex in nature, bar none. Because that tissue contains type 1 collagen, type 3 collagen, hyaluronic acid, differentiated mesenchymal stem cells, and it actually contains some type 2 collagen. I joke and I tell people it's kind of like Arby's. It has the meats, right? It's got all of the collagen-based growth factors our body needs to repair itself at a cellular level. Now, all of you have been in a conference all week on bioidentical hormones. Why? Because as women age, right, they lack the hormone balance to maintain function. Is a joint any different? Is the spine any different. As a matter of fact, it is the exact same. The body needs fuel. You need to supplement missing, damaged, deranged collagen. And if you don't do so, the body can't repair itself at a cellular level. If you have a testosterone level of 50 and you're a male, right, you probably need some supplement. If you have torn your meniscus and you're my age, 53, you need type 1 and type 3 collagen because type 1 collagen ain't going to do it. All right? At the core, the fundamental core of all biologics is two simple principles. Number one, all disease can be laid at the feet of inflammation. All of it. Cardiac, endocrine, renal, infectious disease, I mean, you name it. Inflammation is a culprit. And all of the drugs that we use to modulate inflammation are catabolic. We already said that NSAIDs are catabolic. Many of you may not have seen an article that was just published by the American Academy of Orthopedic Surgeons. 50,000 patients were evaluated who had knee injections. Of the patients with normal knee x-rays who had more than 2 cortisone shots, there was a doubling of the incidence of knee replacement in those patients. Now, this isn't new information. We've known since Journal of Bone and Joint in 2016 that serial application of cortisone aggressively increases the risk for joint replacement. All right? Cortisone's catabolic. Steroids are catabolic. Take any of your patients who are on prednisone for 5 years, 10 years. Do they look better or worse? Their skin's paper thin. Their joints are paper thin, right? Their bones are paper thin. It's horribly catabolic. What about DMARDs? Raise your hand if I decided to give you free methotrexate for a year. How many would take it? Free methotrexate for a year. Who's raising their hand? Who wants that? Absolutely nobody, unless you have to be on it, because it's horribly catabolic. It breaks your tissues down, right? Within Wharton's jelly, you can isolate exosomes, all right? The reason exosomes are so potent is that when they are applied, they systemically downregulate inflammation. The caveat, they are anabolic in nature. Anabolic, right? Within those very same exosomes are collagen-based growth factors, type 1, type 2, and type 3, which are also anabolic and serve as the core building blocks for our body's ability to repair itself at a cellular level. Now, I can talk for hours about this, but I'm going to make life very relevant for all of you, all right? Anywhere you are in the country, anywhere you are, because most of you are probably in private practice, correct? Anywhere you are, there's an integrated chiropractor with a nurse practitioner using a product that's about $700 and charging $5,000 for knee injections. In many states in the country, nurse practitioners can practice independently. And I'm going to tell you a quick story because I got 6 minutes left. A nurse practitioner called me and she said, "Dr. Martin, I need help." I said, "Sure." She said, "I've worked in the ER for the past 10 years. I get paid $700 a shift. And at times I'm seeing 100 patients a shift. And I just don't want to do this anymore. And I'm not going to do it anymore." She said, "I'm moving to Coeur d'Alene, Idaho. And I need your help. I think I want to start a wellness clinic. Can you tell me how to do it?" I said, "Sure. I'll tell you exactly what to do." Because the most profitable model in medicine, bar none, is an IV wellness clinic followed by microneedling for hair loss. Now, all of you are taking care of patients who are perimenopause. How many of them are losing their hair? Like 40, 50% of them, right? I said, "Let's start an IV clinic." She's like, "Great, that sounds hot." I said, "All right." So I tell her exactly how to do that using biologics, right? and we build a value-based paradigm. We use an exosome product that can be administered systemically under research purposes, under experimental use. At her lowest tier, she charged a patient $1,500 for an IV of exosomes, 50 billion exosomes, and she gave them a free supplement of their choice. NAD, ketamine, glutathione, Myers cocktail, you name it, right? At a higher tier, she charged them $3,000, and they got 3 free supplements of their choice, something that I ended up calling the Coeur d'Alene protocol. I walked it all through with her, told her where to get all of her supplies, told her where to get her biologics, right? I didn't hear from her for 6 months. She calls me 6 months later and she's like, Dr. Martin, I have a problem. I'm like, okay, let's do this, right? Because again, I do 50, 60 hours of training a week, and there are some doctors that I talk to literally every week as they're building their practice. And I said, well, how are we doing? She's like, well, actually, I'm doing really well. I said, okay, tell me. She said, well, I see fewer than 10 patients a week, and I'm making about $35,000 a month. How many of you see fewer than 10 patients a week and make $35,000 a month in your practice? I said, well, you're killing it. So what's the problem? She said, I don't know what to do with my time. I said, what do you mean? She's like, well, I'm so used to running all day long and just exhausted. She's like, I don't know what to do with my time. In her community, patients weren't coming in at 7, even though she's there at 6:30. They wouldn't show up until after they dropped their kids off at 9, 9:30. And no patients came after they dropped their kids off or picked their kids up at school. So nobody was coming after 3:30. So I had her close her practice in the morning and in the evening. And nobody came to see her on Fridays, so I had her open her clinic on Saturday. She called me 4 months later. Her revenue had increased to over $40,000 a month by being open from 9 a.m. to 3:30 Monday through Thursday, closed on Friday, and open for 3 hours on Saturday. And she was seeing on average 4 patients a Saturday, netting about $1,000 per patient on Saturday. These are the kind of things that I help providers do. Now, all of you looking at me may think that that's crazy, right? You want to help patients. You want patients to be better, right? Well, I laid out how and why all the drugs that we're using are making patients worse, right? And I gave a lecture to a physician and his staff, and his MA said, well, she's like, well, I don't know that I would do that. I don't know that I can get on board. I'm like, why? She's like, well, is it the right thing for the patient? And I said, well, your provider is going to donate 10% of gross sales every month and split it between the staff, and there's 10 of you. So you have the potential of making an additional $1,000 a month by getting on board with this program. That doesn't motivate you? And she's like, well, no. And so I said, well, who pays the bills in your family? She's 32, by the way. Oh, my mom pays the rent. Who pays for your gas? My mom does. Who pays for your insurance? My mom does. Who pays for the food? My mom does. Who pays for your phone? My mom does. I'm like, what do you do with your salary? She's like, oh, I just spend it how I want. I'm like, well, therein lies the problem. I'm like, but don't you think it would be a great thing to contribute $1,000 a month to your family so that you all can live a better life? And she's like, well, I don't know. What I'll tell you is this, and I have some people roll their eyes because this is an extremely profitable paradigm in medicine. Most practices with very elementary training can add between $5,000 and $10,000 a month to their income, cash. Think about how your lives change adding $5,000 or $10,000 a month to your income. Changes quite a lot, doesn't it? And the way it changes is you can make choices. You can choose to be open on Friday. You can choose if you want to get to the office at 7. You can choose to take a week off without having to worry about any patients that you would have missed in that week. All right? Now, finally, in the last 16 seconds, whether you believe me or not, stem cells are going to be the foundation for medicine 10 years from now. And wherever your practice is, on every corner, everywhere around you, providers are going to have access to these same therapeutics. And so what is going to differentiate your practice from their practice 10 years ago, if anyone can have stem cells and you haven't started to use them? They're not going to see you, because the things that will determine those patients coming to see you will be being early, being competent, being trained, and getting better outcomes than people that are using drugs that are breaking tissues down. I'm Dr. Martin. Please, everyone, have a very blessed day.